Clinical heart failure represents a mechanical inability of the central pump to meet the body's systemic metabolic demands. To understand the failure, we must establish the baseline. A healthy, resting adult heart effectively pumps between 4 and 5 liters of blood through the circulatory system every single minute. This chart breaks down the foundational formula of human survival, cardiac output. As you can see, the total volume of blood pumped per minute is dictated entirely by two variables: stroke volume multiplied by heart rate. By adjusting that output for the physical size of the patient, we get the cardiac index. Maintaining an index greater than 3 liters per minute per square meter of body surface is the strict threshold required to keep vital organs perfused and functional. When that threshold drops, the body initiates a massive systemic response to survive. We are going to track how physical laws dictate the heart's adaptation to stress, how the mechanical structure eventually breaks, and how the body's own hormonal rescue attempts accelerate the damage. The difference between stable health and progressive organ failure lies entirely in this mathematical balance: the continuous volume of blood flow versus the inescapable systemic demand. Here are the 3 mechanical determinants that dictate stroke volume. Preload is the volume of blood filling the chamber before contraction. Contractility is the intrinsic strength of the muscle, and afterload is the resistance the heart must push against to eject the blood. The autonomic nervous system provides immediate, rapid response regulation of these factors. Sympathetic stimulation releases noradrenaline to aggressively increase both the heart rate and the force of contraction, while the parasympathetic system provides the braking mechanism. This visual introduces the Frank-Starling law, which governs how the heart adapts to volume changes. The mechanism is straightforward. As venous return increases, it stretches the myocardial fibers. Up to a point, this stretching physically aligns the muscle filaments to produce a stronger subsequent contraction. However, this law has a critical physiological limit. Stretching the fibers beyond their optimal length ruins the contraction efficiency, causing stroke volume to plummet and initiating the cycle of failure. The heart also adheres to Laplace's law. This states that the heart experiences physical workload as wall stress, a variable dictated by internal pressure and the radius of the chamber, divided by the wall stiffness. To manage increased wall stress, the heart physically changes its geometry. A strict pressure overload forces the muscle to thicken, known as hypertrophy. Conversely, a chronic volume overload causes the chamber to stretch outward, resulting in dilatation. While changing its own geometry allows the heart to survive acute mechanical stress, these physical distortions compromise the flexibility of the muscle. The adaptations that buy time today plant the seeds for irreversible failure tomorrow. When these structural limits are surpassed, the system breaks. This breakdown bifurcates into 2 distinct mechanical deficits. Either the pump can no longer eject blood, or it can no longer fill. This chart categorizes the 2 primary pathways. On the left is systolic heart failure. This is a primary failure of myocardial contractility, frequently caused by direct tissue damage from a heart attack, leaving the muscle too weak to pump. The clinical hallmark of a systolic failure is a dangerously low ejection fraction, with the ventricle successfully pumping out less than 40% of its volume during contraction. On the right, we see diastolic heart failure. Here, the contraction strength is largely intact, but the ventricle itself has become thick, fibrotic, and stiff. It is a failure of relaxation. This creates a diagnostic paradox. A patient with severe diastolic failure will often display a normal or preserved ejection fraction of 50% or higher, because the ratio of blood ejected remains normal, even though the total volume of blood entering the heart is severely restricted. If the chamber wall is mechanically too rigid to stretch open during the relaxation phase, it cannot physically accept the incoming venous return. A normal ejection fraction is a deadly illusion if the chamber cannot fill. Whether the primary deficit is poor ejection or poor relaxation, both pathways fundamentally starve the body of blood. The body is blind to the structural damage inside the heart. It only senses the drop in systemic pressure and interprets this lack of blood flow as an immediate survival crisis, triggering 3 massive chemical alarm systems. This diagram maps those compensatory mechanisms. First, specialized baroreceptors detect the low pressure and trigger the sympathetic nervous system, flooding the body with noradrenaline to rapidly spike the heart rate and constrict peripheral blood vessels. Simultaneously, the kidneys detect the poor perfusion and initiate the RAAS cascade. They release renin, which eventually produces angiotensin II to further constrict vessels, and aldosterone to force the body to aggressively retain sodium. Third, the posterior pituitary gland releases antidiuretic hormone, signaling the kidneys to reabsorb massive amounts of free water to expand the total blood volume. This creates a lethal paradox. These systems increase resistance for the failing heart to pump against, while simultaneously flooding the venous system with extra fluid, creating a massive toxic volume overload. Subjected to this persistent chemical stress and mechanical strain, the heart undergoes maladaptive cardiac remodeling. The muscle tissue develops chronic fibrosis and permanent shape changes, destroying whatever efficiency it had left. The specific neurohormonal cascades designed to rescue the patient from acute blood loss slowly drown and destroy the heart in the long term. The cyclical breakdown of the left ventricle dictates exactly how the symptoms manifest in the patient. As this diagram illustrates, left-sided dysfunction creates two opposing directions of failure: upstream and downstream. Downstream, or forward failure, occurs because the decreased stroke volume starves the peripheral organs. Clinically, this presents as rapid exhaustion and inability to exercise, reduced kidney function, and in severe cases, cognitive confusion due to poor cerebral perfusion. Upstream, or backward failure, is a problem of fluid mechanics. The failing left pump causes high-pressure blood to back up into the left atrium and subsequently directly into the pulmonary veins. This elevated hydrostatic pressure forces fluid out of the pulmonary capillaries and into the lung tissue. Patients experience severe dyspnea, an inability to breathe while lying flat known as orthopnea, and acute pulmonary edema. The resulting edema is suffocating. Fluid steadily seeps into the alveolar spaces, physically blocking oxygen exchange across the respiratory membrane. Because of this retrograde pressure, a primary failure of the heart muscle very frequently presents to the clinician as a terrifying respiratory crisis. This chart introduces the systemic mirror, right heart failure. When the right ventricle loses its pumping capacity, the blood does not back up into the lungs. Instead, the pressure builds in the systemic venous circulation. The clinical manifestations of this systemic congestion include jugular venous distension in the neck, hepatic congestion leading to an enlarged liver, massive fluid accumulation in the abdomen known as ascites, and severe peripheral edema pooling in the legs. This establishes a clear diagnostic rule for the clinician. Left heart failure generates pulmonary congestion, affecting the lungs. Right heart failure generates systemic congestion, affecting the body's major veins. This central flowchart consolidates the entire progression. Initial myocardial damage reduces cardiac output. The body activates the sympathetic nervous system and the RAAS cascade to artificially force blood pressure up. That chronic overactivation drastically increases cardiac workload, forcing structural remodeling, reducing pumping efficiency. Heart failure is a relentless, whole-body progressive syndrome where the mechanisms meant to save the patient ultimately seal their fate.